My name is Dr. Alexander Corns from University of Minnesota. I was one of the co-chairs of a task force that developed recommendations for colon cancer screening specific to cystic fibrosis patients. Cystic fibrosis is a remarkable medical success story. Life expectancy today for cystic fibrosis patients is 42 years. That's median life expectancy. And if patients live that long, they can expect to live for another 20 years. That's remarkable considering it once was a devastating pediatric disease. However, with this success come new challenges. One of these is realization that cystic fibrosis is a colon cancer syndrome. Now we know this from epidemiologic data. CF registries show for non-transplant CF patients, the incidence of colon cancer is about 5 to 10 times greater than the general population. For transplant patients, that risk is even higher. Colonoscopic screening shows that cystic fibrosis is a colon polyp and a colon cancer syndrome with markedly increased number of advanced neoplasms found at screening colonoscopies. And then we have experimental data, both animal and human, showing that decrease in CFTR expression correlates with earlier onset of colon cancer and its faster progression. Now with that, we needed to develop some new recommendations for how do we approach this problem. So Cystic Fibrosis Foundation has helped to organize an 18-member expert task force to go over the literature and the data and develop recommendations for this specific problem. In addition, an independent analysis performed by the Department of Public Health at the Erasmus University in the Netherlands has performed a risk-benefit analysis as well as resource needs for colon cancer screening. And then finally, we solicited feedback from both patients and physicians taking care of CF patients. And so there are 10 recommendations that were developed. These are just the highlights. And first of all, the first one is that decisions about screening have to be individualized between the patient and the physician. And it's because of multiple comorbidities that are present in these patients. Second, at this time, we're only recommending colonoscopic screening, and that's because we simply don't have data on any other modality. Now, for non-transplant patients, screening should start at age 40. For transplant patients, that's age 30, once they have recovered from their transplant, so it's approximately within 2 years of their transplant procedure. That's because of immunosuppression increases the risk and progression of colon cancer. Rescreening for negative colonoscopies is 5 years. Surveillance, once the exam is positive, is 3 years, but it could be shorter if there is significant findings such as advanced neoplasia. Importantly, colonoscopy in CF patients is not quite the same as in general population. These patients require an intensive colonoscopy prep, and an example of that is included in the article. This is for asymptomatic patients. Given that cystic fibrosis is a colon cancer syndrome, we always have to think about it in patients that have symptoms and consider formal evaluation in symptomatic patients beyond these guidelines. Thank you.